This week on the BackTable podcast.
So there's been a lot of big changes. So in 2021, they completely revamped outpatient E&M coding. So for new office patients or established patients, and the significant changes were, used to be you had history, physical exam, and medical decision-making. And then you had time-based billing, but the time-based billing had to be face-to-face. There were lots of rules to it. So the AMA came in and they completely revamped and sort of liberalized the billing and coding for those encounters. In 2023, those same rules will apply for inpatient work. So from an outpatient side, I do a lot of time-based billing, and it's very easy to hit the time requirements because now the time can be face-to-face or non-face-to-face. It can be before, after, or during the day of the visit. And so for most IR patients, we tend to spend a lot of time with them. So from an outpatient side, I really have switched to more time-based billing.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a quick word from our sponsor.
BackTable listeners, we invite you to visit the lab at Reflow during ISET, that's ISET, for a hands-on demonstration of our new and upcoming devices. It's a great opportunity to try out the Wingman crossing catheter with its unique extended bevel tip, the Specs LP, the low-profile version of the Specs shapeable support catheter, and the new line of core catheters for use in challenging PCI procedures. It's the pulse of medical ingenuity at work. See it for yourself at ISET or visit us online at reflowmedical.com. And now back to the show.
I'm your host, Dr. Baheti, coming to you from Tacoma, Washington. And our guest today is Dr. Ryan Trojan, interventional radiologist based in Oklahoma City. Ryan, thanks for being on the show.
Thank you for having me.
So your first podcast about E&M Part 1 was extremely popular. I reference it frequently when I'm going through things. I also reference your YouTube videos and the chart that you made. And when I was listening to it, I kind of felt like there's just something more there that we could talk about. And I felt like there are probably a lot of other people in my shoes. So E&M Part 1 was recorded over a year ago. Have there been any developments in your practice since then?
In my own practice, there have. So we are a fairly large practice. We have 6 to 7 interventionalists and 4 to 5 PAs, but we did not have a clinical nurse practitioner. So we onboarded one last year, and that's been huge in trying to capture all the E&M revenue that's there on the inpatient side, because there's a body that's available to go see all the patients that need to be seen and do the follow-up work.
I see.
I think ideally we would have 2 nurse practitioners for the inpatient practice, but that's something we're working on moving forward.
I think in the last episode you mentioned that at that time the doctors were seeing all the patients, seeing all the consults, doing all of the E&M. So do you guys still go and see those consults?
I typically will. I see all my own patients and all my own follow-ups, but we have some partners that are a little older and aren't as in tune to go see all their follow-up patients.
No way.
So it's been really phenomenal to have somebody who could follow their patients. Okay. And then typically the nurse practitioner will go around on those patients together, but it makes my life a lot easier if she's already done a lot of the groundwork.
Oh, awesome. Okay. So I'm sure that was instrumental in convincing your older partners that E&M was worth it.
And it was one of the things that we noticed where a lot of our hospitalists were like, well, how come this cholecystostomy tube gets clinical follow-up in the hospital and this one doesn't? And I was like, well, we don't have a good reason except for, differences amongst providers in the group. So by bringing in that mid-level, we solved that problem.
That's awesome. That's awesome. And then in your last podcast episode, you mentioned that you guys were starting a clinic, but it was a little bit derailed because of COVID. Any progress on that front?
No. So I was at a lecture at the hospital last week, and they said 70% of hospitals in the past 3 months have lost money. So our hospital system's in that category. So we are trying to find all different avenues to cut revenue. So,
sure.
I think on the inpatient side, the E&M stuff is very easy because it's zero input financially, but still trying to find clinic space, and get a medical assistant and get a nurse all cost money. So to answer the question, no, we don't have that clinic space, and we're still fighting, to get the funding to do that. But I think in the next 6 to 12 months, it's probably going to be a no. We do have a clinic at the hospital. So I have a clinic. I can use my nurses to get vitals, and I see my clinical patients throughout the day. But it's not a deal where, every Thursday afternoon I'm in a clinic separate from separate from the hospital itself, which is kind of what we want. We want a clinic that people can drive up to. They can walk in, walk out easily. And right now, that's not what we have.
So at that current clinic that you have where you have a nursing staff and stuff, is that where you see kind of pre-procedure outpatients, like if you're doing like a elective UFE or something?
So yes, we will see them, but we'll see them, weeks in advance of the procedure. So, it's a moving target on what we see in consultation prior to the procedure. But right now we see all UFEs, anything oncological, whether it be ablations, TACE, we see, and we'll also see them in follow-up. And for biopsies, if we have a patient that wants to see us in consultation before, we will see them. We see all TIPS patients. And then again, everything else like fistula work, vascular access and those things, we typically do not see pre-procedure. I know there are some hospital systems that just see everybody. They see all the ports and all the, I think that's,
wow, yeah.
There's pros and cons to that setup, but we're sort of somewhere in the middle.
Yeah, that's how my practice is too. Like we see bigger stuff beforehand in consults, but anything, a lot of the stuff that our PAs do, we just, see day of. Okay, so you've learned probably a lot over the past year about E&M that you've learned since the last episode. So how has your documentation or management been refined?
So there's been a lot of big changes. So in 2021, they completely revamped outpatient E&M coding. So for new office patients or established patients, and the significant changes were, used to be at history, physical exam, and medical decision-making. And then you had time-based billing, but the time-based billing had to be face-to-face. There were lots of rules to it. So AMA came in and they completely revamped and sort of liberalized the billing and coding for those encounters. In 2023, those same rules will apply for inpatient work. So from an outpatient side, I do a lot of time-based billing on my outpatient consults, just because if I see somebody that's coming in for a renal mass, I'll probably spend 40 minutes with them talking. And it's very easy to hit the time requirements because now the time can be face-to-face or non-face-to-face. It can be before, after, or during the day of the visit. And so you really can, for most IR patients, we tend to spend a lot of time with them. We're not family practice providers. A lot of our patients have a lot of medical complex cases. They've got a lot of baggage to unpack. And so it just takes time to, do the consults and those things. So from an outpatient side, I really have switched to more time-based billing.
I see.
As opposed to, component-based billing.
Yeah, it seems a little more straightforward and a little easier, especially now that you can include all of that stuff in the time. As I understand it, you can also include discussions with the referring provider as part of that time-based billing too, correct?
Yes. So from my standpoint, if we look at it from a inpatient side, from the second somebody calls you, if you're there on a weekend, like let's say I'm working up a stroke, there are a lot of strokes that, I spend a lot of time on the weekends, and all that time can now count. So previously it could not.
Awesome. So that starts to take effect in January 2023.
Correct. And they just released the stuff last month on it. And there are a lot of other changes, but I think from an IR perspective, that's the key change. And I think everybody knew this was headed in that direction. We're just glad it's there. So.
Okay. Yeah. So I think you pretty much answered that next question I had about changes coming in 2023. So are you still gonna go through all of that medical decision-making stuff and all the things that we talked about during the last podcast for your inpatients, or do you think you're gonna just make the switch over to time-based early on?
I think I'm gonna try. Even on the medical decision-making side, they've made that fairly easy. So they've liberalized those rules to where I think what people have to focus on for IR is for outpatient, inpatient, most of our medical decision-making is either going to be moderate complexity or high complexity based on, at least from my patient population. And so I think that it's going to be very easy to time-based bill and to do component-based billing based on medical decision-making. So I think for your run-of-the-mill person who's never billed, it is going to be a whole lot easier to step into this and document what's needed in order to get, your notes covered. And again, I think that with IR patients, all of our patients are complex. Most are complex.
Absolutely.
We're not family practice providers. We're not doing outpatient elective plastic surgery. A lot of people have a lot of medical comorbidities. So
that actually brings us to another point. So Michael Cummings shared this in a group that we have, that he basically got a letter from BCBS that showed where he was coding his visits versus where the average provider was coding their visits. And that letter was implying that he was overcoding his visits. So I'd love to talk to you about reasonable levels of service for various consults. So let's start with like stuff that you see in your outpatient clinic. Start to tell me the kind of things that fall under the lowest code.
So I typically bill, everything is 99, 204, 205. And the times where I'll bill 205, a lot of time has to do with time. So for 205, it kicks in at 60 minutes. And there are some patients that I spend 60 minutes with trying to go over all their medical stuff. So those are the two spots where I bill everything. So I'd be curious to know what level he was billing at that prompted them to send a letter. I've never had from my own experience, I've never been contacted by an insurance company. I think it's one of those deals where as long as you document it appropriately and you're doing the work, they can't have a problem with it.
In my clinic, we see a lot of follow-ups after procedures. So do you document those ones as a level 4 or level 5 as well? Or do you document those as a 3?
Usually mine qualify for a level 4. I do a lot of oncology work, mainly like renal tumor ablations. So that's where I see a lot of my follow-up. And a lot of them have a lot going on. That's how they ended up coming to me.
Sure.
So most are still in the moderate category. Very few are in the low category. If I was going to look at low category, that would be maybe like an infected port that I'm doing prolonged wound care on. That would be something that would fit in the low category. Got
it. Okay. One thing I wanted to touch on, your practice is kind of special in that you're separate from the diagnostic radiologist, right? So you're an IR only group.
Correct.
That is hospital employed, correct?
Yes.
Okay. So I'm thinking, and I went through this with my own group because you mentioned in your last podcast that you can get 2 points for looking at the radiology, right?
Yes.
Looking at the radiology report. I'm wondering if that also applies for folks that are in combined IR-DR groups, because technically it's the same billing entity, right? So I might be looking at a scan, before tips, but one of my diagnostic colleagues has read it. But even though I'm independently reviewing it, since I'm of the same billing entity as the diagnostic radiologist, can I still count that as 2 of my points? You might not know the answer to this question. It's very specific.
I think, because I've thought about this, because it does come up. So I think that since interventional radiology is its own specialty, that you're in the same group, but you're also a separate specialty. So I think it's okay.
Got it. Because it's like a separate board certification now.
Right. And like if you look at, when we look at the changes that were made in 2021 on the outpatient side and will be 2023 on the inpatient side, when we look at medical decision-making, there's 3 components. There's basically problems, data, and risk. They left problems the same and they left risk. They're both pretty much the same. The things that they changed were data, which would be that component of things. Like if I interpret a chest x-ray and I put my interpretation on there, that would count. And some of the stuff they have in there that qualifies would be if you contact a provider and discuss management or test interpretation with an external physician. And the way that they quantify that is if it's a separate specialty, but it's still in your group, it still counts. So from that standpoint, I don't know. So like if you're in a multidisciplinary group where you have vascular surgery, you're in IR, even then, if you contact somebody in your group, that can qualify. But again, they've made the whole system is now fairly simple. So, I'm going to have to delete all my YouTubes and make some new ones that are very simple, because it just makes it to where everybody can do this. And again, I think moving forward, like you said, we're in a diagnostic group. We got hired by the hospital. The private group is still in place at the hospital. But one of our main reasons for leaving was we wanted to provide better patient care.
Yeah.
And you have to have an aggressive inpatient E&M service to where you see every single patient that you touch in the hospital. And on the same side,
Yeah.
you've got to see them and follow up on the outpatient side.
Okay. So in listening to your first podcast, I heard the part about global periods. I'd just like to go over that again, just for some clarification, and just because I think it's a really important part to understand IR E&M. Just explain the idea of global periods again to me.
So for global periods, you have 0-day globals, 10-day globals, and 90-day globals. For IR, we pretty much just focus on the 10-day globals. There's the things that fall into the 10-day global are kyphoplasty, tunneled central venous access, cholecystostomy tube placement, gastric access, so like a fresh GJ or fresh G tube, and then any sort of ablation. So anything outside of that is a 0-day global. And the significance of that is, and it's very, very, very important, is that hospital day 1, you can bill inpatient progress notes. And if you were to see them in clinic 5 days later, you can bill for that encounter. We are unique in that most specialties have 10 and 90-day globals. We do not. And one thing to highlight, for example, I think you had a question about phlebotomy.
Oh, phlebectomy. Yeah, I think, I do that in my practice. So maybe you don't do it in yours, but yeah, I think I just saw that they changed it to a 10-day global also.
Yeah. So for example, the phlebectomy codes, which I do not do. So looking at those codes, this highlights exactly what happened to IR the past 10 to 15 years. So everybody says IR's taking it in the shorts, reimbursements in the tank. And what happened is they dropped payment for our code. So look at the phlebectomy code. They dropped payments. I believe those codes were 31 to 32% less in production than the year prior. But then they moved it from a 90-day global to a 10-day global. And if you look at what they did with IR procedures, it was the exact same. They take a biliary drain placement, cut the pay 30, 35%, but then they drop it to a 0-day global, thinking, well, he functions just like a urologist. And if you do that to a urologist, he's going to follow the patient every day in the hospital and see him in clinic, and he's going to make up for that lost revenue with E&M. But again, the vast majority of IRs aren't capturing that revenue for E&M work, because I think the most common thing I hear is it's not worth it. And I just don't think that's true. I think in the landscape as it stands, we should try to capture every bit of revenue we can, and not leave anything on the table.
Yeah, it's just one of the ways that IR can show that they're not a cost center, really, and that they're a producer for the hospital or for their group even. Okay, well, thanks for clarifying that. And so just a couple more things. Are these only for inpatient services or for outpatient services too, and stuff in the OBL?
So I do not work in the OBL space, but my interpretation is this applies to everything that we do. So if you put a port in an OBL and you see them, post-operative day 3, you would not be able to bill for that as that's a 10-day global.
I got it. Okay. All right. Perfect. I think you mentioned before, but cholecystostomy tube placement is on there, but biliary tube placement is not on there, correct?
Correct. It makes no sense.
It makes no sense.
I think I think they went in and they audit these codes and they try to bundle everything, and then cholecystostomy tube is sort of like the bastard code. It's just out on its own, and they'll just never come back and fix it. Because
it's like, you stay over there.
And from an RVU standpoint, like, I think it's falsely high compared to all the other biliary cases we do.
What is it?
I think it's like, I can look it up. Let me look it up. I think it's like 7.
I'm curious.
So cholecystostomy tubes. So it's 4.7 work RVUs, but it's the exact same. So biliary drain placements, 5.38. So I feel like a lot of biliary drain placements are much more difficult than a cholecystostomy tube.
Well, yeah.
So,
wow. Yeah. Yeah. Well, there you go. I know what I'm doing tonight. I'm just kidding. I'm not going to go place a bunch of chole tubes. Well, actually, I might. I'm on call. All right. I'd love to get to some questions from the audience. I pulled Twitter about this podcast, and I wanted to kind of hear what other interventional radiologists had to ask you. I've been told that I can't be the ordering MD on a consult. I'm wondering if that's true, as I've seen vascular surgery use the lab as the ordering doctor. For example, I'll get a call from GI about a bleed. I see the patient and say angio is warranted. I have been told that GI has to order the consult or procedure in the EMR, not me. Is that true?
My understanding and the way that I practice is that I typically don't have an order in the system. So if GI calls me, I'll go see the patient. I put the note in, and I'll say referring provider is my GI specialist, and he called me to come see the patient about X. And so I documented in my note who my referrer is, why I'm being referred for the case. So for the inpatient consult codes, right now there's 5, 99251 through 99255. In the 2023 update, they're getting rid of 99251. And that sort of mirrors, there's, 4 categories for medical decision making. And so each of those categories will be tied to a consult code.
Mm-hmm.
So as long as you document, again, the physician that requested the consult, why they wanted the consult, and document the note appropriately, it should be okay. If I see a patient where it's I think that one of the caveats is, who do I write a consult note on versus who do I write just an inpatient hospital day 1 note?
Let's touch on that.
And I think that's a sort of up to everybody's interpretation.
Okay.
So about 50% of my consults, or if you consult me in the hospital, 50% of the time, I'll bill it as a consult note because I really talk to the patients. Like, for example, let's say cholecystostomy tube. I would bill that as a consult because I have to go over expectations. Having the tube in, a lot of people freak out when they're like, oh, I'm going to have a tube for 4 to 6 weeks. I have to follow up with the surgeon to make sure the gallbladder comes out if it needs to. And a lot of those patients have a lot of medical stuff going on to where it's just, I got to spend a lot of time talking to them about expectations.
Sure.
But if you were to call me for a non-septic, well, I take it back. I typically just consult everybody.
Oh, really?
And then on the back, I don't know. I'm trying to think of situations on the inpatient side where I wouldn't make it a consult, and I can't think of any recently that I've done in the past 6 months.
I guess for me, like if thoracic surgery consults me to put a chest tube in, I'll see them write something about it, but it's not really a consult because I'm not really given the option to give the patient yes or no. You know, I'm not sure.
And I think in those,
something like that.
So in cases where it's not a consult, like a chest tube, I just typically do it and just see them on the back side, but I won't typically see maybe that patient on the front side.
Got it. Oh yeah, that kind of brings me to the next question. Should all procedures come as a result of a formal consult, or how do you triage what things are minor, what things are major?
I don't think there's like a hard and fast rule, but typically, like for example, a chest tube I wouldn't see on the front end. I would just follow them on the back end, and then anything
and do the hospital progress notes. Okay.
Anybody who's going to have a drainage tube long term, I'll typically see that patient in consult just because I know I really want to work on them to set expectations. I think it's on the flip side, if I'm the patient and I end up in the IR department and then somebody's telling me I'm going to have a tube for 6 months or 3 months, I could see from the patient side where that would be, cause a lot of anxiety and worry and all that stuff. But if they come down knowing exactly what you're going to do, I just think it's a better patient experience.
Oh, yeah, absolutely. Yeah. It kind of solidifies our role as real doctor. I don't hate saying this, but real doctors, a surgeon wouldn't just operate on whoever showed up to his operating room, right? Have to do this pre-procedure workup beforehand. And I think that's something that's lost in a lot of folks that maybe didn't train the way we trained.
I think so. And I think the IRs that have been coming out the past 5 to 10 years are a lot more in tune with that aspect of it. And even the first 6 months I was in practice, everybody was like, why are you always up in the ICU rounding? It's like, I thought this is what we were supposed to do. So
yeah. Well, it sounds like you've kind of faced a lot of similar challenges to me in terms of managing expectations with your older partners, perhaps, or with, not in your case, but in some cases, diagnostic radiology. So I know you hired the NP. Anything else you've kind of done to get the older rads on board with the way that you do stuff now?
So for the record, the one older rad is not on board with rounding on patients.
Oh.
And we just had to cut our losses. So I round on all of his patients.
Oh, okay.
And so when he's on vacation, they come to me because they already know me. I think the main thing is templates, not necessarily I don't have a template for every individual scenario. So I don't have on the inpatient side, I've got 2 or 3 templates. On the outpatient side, I have a UFI template. And that's just to speed things up. But I think having templates that you can share with people. So if we onboard a new provider or even a nurse practitioner, she has access to all of our templates. And so she doesn't have to reinvent the wheel as far as making a note that looks good.
Oh, yeah, absolutely. And in Epic, it's so easy. You can pull in everything and it's just a pretty easy EMR to use. Although I'm sure a lot of people would not agree with that.
And I am shocked how many people don't know how the snipping tool. So yeah. I will. So 2 things I do that I like. with Epic. I think Epic's phenomenal. I know people hate it, but I've had a lot worse. So I'll snip the pictures off packs, and then I also have Epic on my iPhone. So if I drain like 3 liters of pus out of somebody, I'll snap a picture on my iPhone. It uploads their Epic chart, and then I put it in the post-procedure note, and people just love it. The ID docs love it.
Oh, man. Yes. Yeah, no, I mean, nothing like a big bowl of pus to just like make somebody's day. Just think of like some hospitalist eating their lunch sandwich and like looking at that progress note.
And I like to stick something in there for reference, like a bottle cap or a syringe, so they can just know the volume.
Definitely. I wish I could do that on my EMR. There's like all this like weird software, so I can't use snipping tool. I know
That's a bummer.
Blowing my mind, but I know it's really hindering my my lifestyle. But I'll text people, pictures of stuff. I'll text referring providers gross pictures of clot I've taken out, all that stuff. I don't know if they like it or if they just want to be like, lady, please stop sending me these. But I'm going to keep doing it.
So in regards on that topic, in the new rules that come out in 2023, if you reach out to an external provider via text, that counts as a qualification for one of the data points. So it used to be, I think people thought you had to call, but now you can text or Skype or whatever you want to do, and that counts.
Oh, that's great.
So
that's awesome.
I think one thing I discounted starting my IR practice was I didn't realize how much I would be texting people. It's like all day.
Oh, for sure. It's good and bad, right? That they always have your number.
Yeah.
Any other tips and tricks from the AMA updates that you'd like to share with us?
So not really. I just think that hats off to them for moving in the right direction to simplify things.
Yeah.
So that, it's a lot easier to capture this kind of stuff. And again, I think, it's almost 2023. I think every IR group should have a healthy and robust inpatient and outpatient clinical service. And I think if your group is trying to hinder you in doing that, I think you're providing the patient care is not as good as it could be.
For sure.
And like you said before, like any other, like a urologist or general surgeon, they all have these notes in the chart. And we may be the rock star that's doing the bulk of the work, but then we're not in the chart. I can think of multiple times where cardiothoracics was consulted for a lymphatics leak, and then I come in and fix it. And then cardiothoracics just follows and follows and follows, and they've not done anything but referred them to me, but they're still billing the clinical follow-up.
Well, that brings me to a good point. Do you, in the way that my practice is set up, the PAs usually will round on people and they might sign off on them day one post-procedure. Do you typically follow your patients the whole time while they're in the hospital or just until their problem is done?
So it depends. If it's a nephrostomy tube, if it's a drainage patient, I will follow them for a couple of days. Like let's say it's a nephrostomy tube, they have cancer. I'll follow them for a couple of days. And then if I'm not providing any expertise, then I'll sign off. If it's an abscess drain, I will follow them the entirety of their stay in the hospital because I'm pretty aggressive about either re-imaging, adding drains, and I think that helps. We have a lot of pancreatitis patients, being the Hepatobiliary Surgery Center of Oklahoma. We end up seeing that a lot. So that's an example of somebody that may be here 60 hospital days, but I'm probably going to see them every day that they're here, at least Monday through Friday. On the weekends, I typically won't follow them because nothing's going on. And then on like a biopsy, I'll see a biopsy the next morning, make sure they didn't bleed overnight, and then sign off.
I see. Okay. So you do follow your biopsies next day too. Got it. Awesome. And then are there patients that you like chart check and write a note for, but maybe don't go see? Or are you pretty much seeing all these folks?
I go see everybody because I found that whether you see 3 people or like 15, it's almost the same amount of time. Unless
Isn't that amazing?
Unless you have a crazy patient, but you just have to be really good about trying to stay focused.
Yes.
And one thing I think, and I'm not as in tune to this, would be the telehealth stuff.
Yeah.
I still think there's a lot of indecision. I don't think we have a clear vision of what telehealth is going to look like in 2023. So I think once that update occurs, I'll try to do a YouTube. And then I'll probably put out some YouTubes that reflect all these changes because the ones that are up there are pointless at this point. So
I still like them.
Yeah.
But yeah, you're right. They won't be super helpful in a few months here.
And again, when it comes to the new stuff, all you have to do is put in a history and physical that you think is necessary, whatever that is.
Got it.
So for me, I do the skin. I'll say drain side is clean, dry, and intact. And I'll say what's in the drain bag a lot of times, and that's it. And that's so I don't. I don't typically bust out a stethoscope or any of that stuff on, depending on what's required.
For sure. Yeah. It's like, it's stuff we're already doing, but we're just maybe not getting appropriately paid for it. Okay. Well, I feel like we covered a lot. We got into like some nitty gritty details that I wanted to clarify. So thanks for that. Any other words of advice to folks who maybe either haven't started on their E&M journey or have gotten maybe hindered on the way there?
I don't know. I think just the main thing is you just have to do it. Just wake up.
It's like sex, right? Isn't that what you said?
It's like sex. You just have to do it once and then all the anxiety's gone. So, and it's like one of those deals, like if you're not doing it, you don't know what questions to ask. So you do it a couple times.
Yeah.
And then you'll have really good questions. People can email me. It's ryan.trojan@integrisok.com if you have questions.
Okay.
And I have a question for you. Where did you do your fellowship training?
University of Virginia.
So did you guys get trained in E&M coding?
We sure did not. No, we did all the clinical stuff that you're talking about, but no, I didn't, but my husband, just like your brother who's a urologist, my husband's an ear, nose, and throat surgeon. And so a lot of the things that I've learned has been from him. And when he saw some of the ways that we were losing money on E&M coding for a lot of our clinic stuff, he was like, I can't believe you guys are doing this. This is, I can't believe you can run a clinical practice like this. So that was a real eye opener for me.
Yeah. And my brother as a urologist, they're like savants when it comes to coding because they live or die based on their clinic coding skills. Same thing with ENT. I trained at Hopkins and we got zero training, not to knock on Hopkins, but they do have an outpatient clinic, but then we never got any training or skills to apply it to our jobs moving forward. So I wish we could come up with a standardized curriculum for fellows to find a way to get this information out there. So at least they had the tools that when they hit the ground running, they could implement E&M billing where it's not being done.
Well, we could even, if you were interested in collaborating, we could even put together something for the SIR Fellows Practicum,
okay.
The one that they have in the spring. That's kind of just like a basic intro thing, just like you said, to hit the ground running.
Where is it?
Gosh, I went, but it was a few years ago and I don't remember. But they just have I think Parag Patel was running it that year, but they just have like a bunch of lectures by different folks. Some of them are really academically oriented. Like I remember this one lecture about like doing crazy cases with AngioVac. And I'm like, I'm never going to use AngioVac in my life, And then a lot of this stuff is a little more private practice oriented too.
Okay.
So it might be a good forum for an introduction.
Okay, cool.
Awesome. Okay, well, Ryan, thanks so much for coming on the show. I really appreciate it.
Thank you very much. Have a good day.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dond, Michael Barraza,
and Ali Baheti.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar.
Social media and PR by Ann Dang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.